We are going to hear from 4 esteemed panelists today about tools, big and little, to make behavior change easier and more appealing. They'll talk about how to reduce individual and community barriers, and they'll share insights on how to go beyond health education, or as we heard this morning, telling people what to do, and leverage technology and data to empower people to change. I'm going to introduce the panelists very briefly. You can read more about them on the app, and then we will launch into individual presentations, and then I'll ask a few questions afterward. Rebekah Russell-Bennett is a professor of marketing at Queensland University of Technology in Australia and an expert in using games and mobile technology to encourage behavior change. Melichar is a labor economist who directs the Pioneer portfolio at the Robert Wood Johnson Foundation and hosts the Foundation's Pioneering Ideas podcast. Patrick Sullivan is a professor of epidemiology at Emory University and the principal scientist for an interactive tool that maps the U.S. HIV epidemic. And last but not least, Kim McCoy-Wade is the chief of the CalFresh and Nutrition branch for the California Department of Social Services, where she runs the food assistance program for 4 million Californians. So we will begin first with Rebekah. Thank you.
Well, g'day everyone. Very happy to be here in San Diego talking to you about gamification. So I'm from a school of marketing, and so the perspective that I'm going to give you is very much from a business school's perspective. So when I got the brief for this, I was told to talk about how gamification can help remove some of the obstacles or the barriers to behaviour change. So what I'm talking about here is when the behaviour is needed, but where it's difficult, where the competition might be more appealing, where there's a time lag for results, where there's a lack of relevance, or there's a lack of a value proposition for people. So the examples I'm going to give you are really contexts where there's low involvement, where there's low interest, and where the behaviour change is not wildly exciting. So if any of you are in those kind of contexts, then gamification might be an area or a tool that you can use. So I guess the question first of all is why digital? Sometimes people just default to digital. They think we've got to have an app, or we've got to have a website, we've got to have a Facebook page, we've got to have something digital because everybody else is doing it. So the first point is why digital? Well, it is everywhere, but you need to use it strategically. So here are some examples of how digital is affecting us. So if you want to quit, you can download an app. And you just simply select the reason for quitting, put in your boss's phone number, and it will send a text to your boss and quit under a variety of different reasons. In Sweden, they did a really great condom campaign. What they did was they handed out condoms that had barcodes on them that you could scan in, took you to a website, and then you registered the profile. Now, when you were then using the condom from the condom you've been given, you clicked on the app that you downloaded only via the condom packet, and then you could record a range of different sounds, duration of your nocturnal activities. That information, including decibels, duration, was then mapped onto your profile, and you could then download and get a t-shirt printed about how long blondes can last, the time it takes between an electrician and a marketer, and so on and so forth. They then use that information to then engage conversation and make what is potentially a very embarrassing topic discussed. And it worked really, really well for them. We've also got apps that tell you who you gave a gift to. So if you've got multiple girlfriends or boyfriends, it's really important to know who you gave what to. People are engaging with digital. We need to be in this space. It's a variety of interactions. And then finally, if you can't remember when to drink water, there is also an app for that. So people are engaging with digital. So it's not a question of should you have digital, it's a question of how you use digital, and you must make it strategic. So what is gamification then? Well, it's the process of combining game-like elements with information. It's not necessarily games. It's taking things like leaderboards, competition, and putting it into some sort of information environment. This is a huge industry. In 2006, it was worth $2.8 billion. It's increased from 2012 from 242, and it's expanding. And what's interesting is it's coming out of just the entertainment industry into the serious games area, which is the area that we all are involved in. And it's not the same as games. So how then do games affect our brain? So there's a whole neuroscience around the notion of gamification and what it does to us physically. So consumers are hardwired for play. We naturally enjoy play. So when we're doing campaigns or programs for topics that are boring to our consumers, why do we make it boring and difficult for them? Why are we not engaging what they do naturally, and that is play? Games facilitate behaviour through motivation, they can help provide opportunity, and they can build skills through simulation that then translate into real-world behaviour. And finally, they can provide psychological payoff. So those of you who are familiar with self-determination theory will know the concepts of autonomy, mastery, and social interaction. So there is a lot of research around that motivation and how games can provide that kind of motivation. And the way that they work is games stimulate the very central part of our brain and trigger emotions. And when we have emotions, and they are also linked to hormones. So when we get that dopamine and serotonin hit that comes from playing a game, we're getting physical reinforcement. This is good. Now the trick is to make sure that the game is linked to the real world behaviour. There's no point in having something that's great fun, but when you're finished, it means nothing. But once we're triggering emotions and hormones, what we then start to do is have information embedded in memory and learning. So if you smell freshly baked bread or something that takes you back to your childhood, it's because emotions and memory are linked. The more we can trigger an emotion, the more we're going to have information embedded in memory. And that's what we want, particularly for topics that aren't wildly boring, where people just don't want to get the information. We need that information to be embedded. And by linking to emotions and hormones, we can actually have a better shot that they'll remember. But of course, we need to make sure that we translate this behaviour. So why do consumers like gamification? They like it because it can be competitive. People like to compete. They want to be rewarded for the behaviour. If we're helping people to eat healthier, the rewards do not come instantly. Oh, wish they did, but they don't. You'd go to the gym and you just immediately want to jump on the scales. The weight's just not shedding. That's really not reinforcing for me. But if I'm playing some sort of game or doing something that encourages activity, then at least I'm getting a short-term hit that's giving me a dopamine rush, making me feel good about myself. I can get those short-term rewards that may help me engage further. People like to be participators. They want to give reviews. TripAdvisor is based on that. Let people provide information back. So it's a circular process. It's not one-way communication. And then finally, we want to connect people. So if we can connect them socially, that is a really strong motivator, and games can help you do all of those. So I'm going to play this short video for you about a case study of an app that reduced smoking in pregnant women, and I'm going to give you the details about it. So it was an app that had games. You could pick your baby name, play games to avoid the cravings, and it also gave you information. It's called Quit for You, Quit for Two. So it's pretty cute. So there were 3 barriers that this app addressed. Physical cravings. The games were designed to last for 3 minutes, the approximate length of a craving. So it was a distraction technique. It was also aimed to build self-esteem and literacy. If you are pregnant and smoking, you are one of the most stigmatised groups in the community. People will tell you off in public. When you are pregnant, you become public property, as many of us know. And that is particularly the case when you're smoking. So this is not something that people tend to go to the doctor about and say, I'm smoking and I'm pregnant. It's very shameful. And so it's a small group of people, but it makes a really big difference. So the details are up there on the slides for you, and the game worked because it was based around a single insight about distraction and cravings, worked very effectively, had high downloads. This second case was all about electricity use in the home. And I'll just get you to turn the sound up.
Juice Your Juice, an innovative new energy efficiency behaviour change program, purpose-built for a new generation of digital natives. The program uses the strongest connection point for this unique group, their mobile phones. Around 9 in 10 under 35s own a smartphone and check it on average 56 times a day.
Reduce Your Juice is an evidence-based program that was developed in collaboration with behavioural change experts at QUT.
It taps into cutting-edge approaches to engage an audience otherwise disinterested in learning about energy efficiency. Reduce Your Juice is a unique ecosystem of games, social media community, email and SMS communications, designed to point users in the direction of their goal, to slash their energy bill. It's built around 3 core principles: make it fun, social and competitive, and uses both intrinsic and extrinsic rewards to motivate behaviour change. The results are truly impressive. Participants' power-saving habits improved by 23%. And on average, they saved $220 annually. Significant positive change towards energy consumption resulted in more manageable energy bills. The program has been well received, with positive feedback from participants via social media and email.
Good way of reducing energy costs.
I think everyone would benefit from this program.
Opens your eyes to what is more important and how easy it can be to save.
Okay, I'm out of time. Thank you very much.
I think I might download that energy app for my husband, who cannot turn off the lights. Okay, now we're going to move to our next speaker, Lori.
Thank you. I'm thrilled to join this panel of experts. You'll see that our first speaker answered one of my hypothetical questions, so that should make my talk go a little bit quicker. It's also thrilling to be among so many agents of change. Your energy and your passion is really inspiring. And I'm also really lifted up to know that so many of you, like me and my organization, are working towards a future where all Americans from all walks of life have an opportunity to live their healthiest life, where we live in a culture of health. So you know what I mean by a culture of health, don't you? So I'm a mom, so for me, a culture of health means that all moms and dads are able to feel safe and know that their kids are safe playing outside. All parents can walk to grocery stores and purchase fresh fruits and vegetables for their family, and all members of families are able to afford to go to the doctor to get their needed shots and checkups. Now, you may have your own vision of a culture of health. Maybe for you, a culture of health is where all important decisions are made with health in mind, from how we build our towns and cities, to how we structure our school day, to how we design our office cubicles. Or maybe for you, a culture of health is when incentives are aligned with systems to make the healthy choice the easy choice. I'm sure for many of you, in a culture of health, technology shifts from being something that can be distracting and isolating to being something that's engaging and can help people connect in real life. So several of my panelists have pointed to and will point to examples where a culture of health is actually here today. And I'm really lucky to live in New York City, where I live in a neighborhood that makes it actually really easy for me to live a healthy life. On my very block, there's a ride share, there's a bodega with fresh fruits and vegetables, there's a yoga studio. I live a block away from a park where my kids can run and play, and 2 blocks away from a running path where you can run all the way up the river. But you can't say that most people in the United States live in a neighborhood that makes it easy for them to be healthy. In fact, 1 in 5 Americans live in neighborhoods that make it really hard for them to be healthy. On top of that, many face discrimination that prevents them from getting access to the care that they need, the jobs that they need, and the housing that they need. People in Beverly Hills live 7 years longer on average than people who live in Compton. That's only 22 miles away. So, to eliminate these disparities will require us to change systems and policies and environments, to build more bike trails and sidewalks, to more parks, to put more fresh fruits and vegetables in grocery stores, just for starters. But we need to do more than just create opportunities for people to pursue good health. We also need to make sure that the people in the communities that we support are ready and able to take advantage of these opportunities. After all, 30% of our health is determined by our individual behaviors, whether we smoke, drink, or exercise, and this means we also have to support Americans in their efforts to make healthy choices. It's not enough to make sure that the healthy option is available. Who hasn't approached the snack table during a break at a conference to find the unhealthy options right next to the healthy options? What do you usually go for after sitting in about more than a half day of meetings? The cookies or the apple? Me too. Why do we do that? It's not that we aren't knowledgeable. We know that the apple's better for us than the cookie. We know the cookie is only going to please our taste buds for a fleeting few seconds. We actually like apples, but we just don't make decisions based on knowing what is right or wrong, good or bad. So how do we make the decisions that affect our health? RWJF, we've been exploring, trying to find answers to that questions. We've been learning from neuroscientists and behavioral economists, social psychologists, political sciences, and people from other disciplines. And they have been proving what we have been observing for a really long time, that humans just aren't rational. We don't always make decisions that are in our best interest, even when we say that we want to. And even showing people evidence of what's helpful or harmful for their health doesn't often work to change their behavior. Instead, we're emotional. Both anger and happiness can skew our decisions away from the logical. Anxiety and passion can cloud reason. I heard a story on NPR the other day that says a lot of people are avoiding getting the flu shots that could potentially save their lives because they're scared of needles. And I have to admit that I've actually I had put off getting my son a flu shot because he was scared of needles, even as I was encouraging other parents to get their flu shots. We're social, so what we perceive to be acceptable behavior or common behavior between our friends and our coworkers and even citizens in general makes us more inclined to do the same. This phenomenon promotes health when our coworkers drag us to the gym, but it can be harmful to health when our coworkers email when they're on vacation. Context counts. Our behaviors both reflect and reinforce our environments. At its best, our healthcare system is full of cues and symbols that promote health. The white coat, the soft, soothing voice, the gentle touch. They instill a hope that we're going to get better and a belief that we're going to get better. But at its worst, our healthcare systems are depressing places that cause us to lose that hope. Mindsets matter. The way we think about something, whether that's diet, exercise, or even our doctor's advice, can not only influence our behavior, but it can produce an actual physiological response. The same exact drink can produce more of an impact on the body's hunger-regulating hormone if we are told that that drink is an indulgent milkshake than if we're led to believe that it's a guilt-free smoothie. So over the past 8 years, we've been experimenting with some cutting-edge ideas, some ways to change behavior. These are ideas that tap into people's emotions and mindset, harness their social networks, and reshape the context in which they're making their decisions. And we've uncovered some ideas for solutions that at their core are really simple to implement. They're relatively low cost and they're easy to scale. So here are a few things that we can all try. We can make the healthy choice the easy choice. My employer makes it really easy for me to save for retirement by taking money right out of my paycheck and putting it right into my 401k before I even see it. We can make it easier for people to stick to a plan to eat healthy by not putting the cookies right next to the apples. Better yet, we can make the healthy choice the default choice. Restaurants have been testing this with some success by having a side dish of something healthy like a strawberry or a salad be the default side for kids' meals. And in this way, there have been more healthy meals served. We can tweak the physical environment in ways that will nudge people towards healthy choices. Visual cues like these red, yellow, and green tongs, which you can find in the cafeteria where I work, signal to my coworkers and I, almost unconsciously, what we should be filling our plates up with. And the fact that the green tongs are towards the front of the salad bar where our plates have more room makes that easier as well. We can spread healthy habits and norms from person to person in much the way that a runny nose spreads its way through my kids' kindergarten class. We can harness the bandwagon effect to influence decisions. Students who were heavy drinkers at the University of Northern Illinois University thought that all their peers were binge drinkers. And when they learned that their peers only drank moderately, their alcohol consumption dropped as well. We can rewire the way that we think about healthy behaviors. When hotel cleaning staff were told that and reminded that their work was actually exercise, they burned more calories than hotel cleaning staff who did the very same amount of work who weren't given a similar cue. When diners were reminded that healthy foods can be indulgent and tasty, when carrots, beets, and green beans were described as dynamite, caramelized, and sweet sizzling, people ate more vegetables. We can use data to micro-target our interventions. As Jeff pointed out this morning, even when public health interventions are targeted, they're usually aimed at broad swaths of the population, mothers, children, people who are a certain weight. But with the recent explosion of data, not to mention the advances in machine learning and also emerging insights from genetics, we can and should get micro-targeted. By applying analytic techniques to the vast amounts of data that's being collected about our consumption patterns and our habits, we can deliver people pick the exact right person to deliver the exact right message to at the exact right time to help change their behavior. Because people's insurance status isn't something that's publicly available, my foundation funded Enroll America to create a database and to analyze that to assess the likelihood that a person was uninsured to be able to target their enrollment efforts. So the data is out there, but sometimes we need to think creatively about how we can access that data, from partnering with retail pharmacies or a grocery store, or even the maker of a particular app. What might we try if we had data that told us that a smoker was pregnant? So all of you have heard about personalized medicine. I'm sure maybe fewer of you are familiar with the term personalized public health. Combining data with about the social determinants of health with genomic, epigenetic, and microbiome data could show us who's at risk for obesity and heart disease, and combined with data about how their health behaviors, we could figure out what kind of intervention is right for them. We're not far from a future where public health leaders target people in ways that are personalized to their biological makeup and change their whole health trajectory. We can be more agile in how we deliver the interventions. Traditional evaluations of public health interventions care a lot about implementation fidelity, sample size, and holding as many variables constant as possible. And while these are crucial characteristics of a high-quality evaluation and rigorous research study, behavioral health interventions might also benefit from a model used by tech companies. So let's not assume away complexity, but let's test our assumptions by iterating on beta versions with diverse populations to get to real-world impact faster. Don't get me wrong, rigorous research is essential. Many of the results that I've shared today are based on very rigorous studies, but we also find cutting-edge ideas from makerspaces and from DIY labs across the country, from those who are involved in what's called citizen science, and from patients themselves who are doing N-of-1 studies. I also learn a lot from coming to conferences like this. I'm looking forward to hearing more and learning more from all of you. I'm sure that much of the science that I presented today is not new to you, but I'm hoping that my talk today spurred some new ideas or slow hunches in your heads about how to improve health. I hope you'll tweet me or email me so that we can all work together to try new things to try to make the healthy choice the easy choice.
Thank you so much. It really seems like maybe it's not an entire overhaul, but just a tweaking of some things to improve health. Thank you so much. We're going to move on now to Patrick.
Thank you. Good morning. Maps. Maps tell us where we are. They tell us where we're going. Maps help us locate a doctor. Maps help us find ourselves in a community. And when we start to locate ourselves in maps, that's when they become really powerful. Think about it. You don't care so much about that long list of pharmacies in the phone book. All you want to know is where's the closest Walgreens so I can get my cough medicine. Technology has inspired personalization in the palm of our hand, and now it's commonplace. But I grew up in science in a different world. I grew up in a world of data. In a world of reams of data, often in tabular formats, surveillance data. And although these data are really high quality data, there are different ways of seeing data. There are different ways to communicate different things with data. And seeing data in new ways can lead us to new actions. Not everybody looks at data in tables. So by taking these data and transforming them into maps, we make the information more understandable, and we can democratize data for large-scale public awareness. Let's look at how this works. I lead a project called AIDSVu, and our goal is to make data about the US HIV epidemic widely available, easily accessible, and locally relevant to inform public health decision-making. We provide planners and providers and people with a public health tool that lets them educate, advocate for critical issues, and make strategic decisions about where to place resources. On AIDSVu, we take these tables of data here about the HIV epidemic, and we change them into maps. We work with the Centers for Disease Control and Prevention to get data about HIV at the state and county level, and we work with city health departments, state health departments, and county health departments to get data about HIV down to the zip code level in 41 cities. These zip code level data let us paint a picture of epidemics in the US that cover 60% of all the HIV cases in the US. So let's take a look at a state like Illinois. If we want to plan programs, what do we need to know? This first map shows us the number of people living with HIV in the state. We can also look at something slightly different, which is the number of new diagnoses that have occurred in a recent year. It's also important to understand how many people have died while living with HIV. We can then zoom in a little bit further and look at the county level data. This gives us a more granular picture, and it lets us see a much clearer picture of where the epidemic is concentrated within the state. We can look at Chicago. This shows the concentration of people living with HIV in the city, down to the zip code level. And when we zoom in further to the census tract level, we see more detail still. Why is this important? When we compare the data from the zip code level on the left with the census tract level from the right, you can see how visualizing data at a more granular level helps us more clearly identify the hot spots, those specific neighborhoods where we need to be providing HIV prevention and care services. AIDSVu also has service locators that let people find resources they might need, like where to get an HIV test, where to get care for people living with HIV, or where to talk to a provider about pre-exposure prophylaxis, which helps prevent new HIV infections. So I'm going to quickly tell you 3 stories today, the 3 Ps, about planners, about providers, and about people, and how they can use these data to change behavior. First, we'll think about planners. Now let's imagine that you work in a health department and you're looking at services in your state. Or maybe you work in a community-based organization and you're getting ready to apply for a grant. Wouldn't you like to know whether the services that are being provided are being offered in the places where they're needed most? This shows a look at HIV prevalence in Atlanta, the concentration of where people are living with HIV. This is my hometown. In Atlanta, we're analyzing the providers offering PrEP, which is an HIV prevention tool, and the areas of the city where we're seeing new diagnoses. So here we can look at this map that shows where people are being diagnosed with HIV, where new infections are occurring. And we can then layer over PrEP services. These are these little black pins. These are where physicians and other providers are actually prescribing the medication that can prevent HIV. Ideally, we'd like to see that the places where new infections are happening overlap closely with the places where pre-exposure prophylaxis is being provided. But what we found in Atlanta is something different. In fact, there's a big PrEP desert that's in the southwest part of the city. What this means is in the places where most new HIV infections are occurring, the very tools that could help stem that tide are not being provided in the same locations. This is a call for health departments and other providers to develop innovative ways to take the services to the places where they're needed most. Just seeing these data motivates people to do innovative things to try and meet the needs that have been identified. So if you were faced with a map like this that shows a big gap in services, what would you do? Planners, what would you do? You would find more providers and you would make sure that they are put into the places where they're needed most. The people at Medical Advocacy and Outreach in Montgomery, Alabama were faced with this same situation. So let's take a look at what they did. This AIDS service organization overlaid the AIDSVu map of HIV cases on the left with a map of healthcare provider shortage areas that you see on the right. And when they overlaid these maps, they identified areas with the greatest needs for HIV care that weren't being met by providers. And these turned out to be in rural areas of the state that were in some of the poorest counties of the state. So what they did was develop a telemedicine program in these rural areas in which doctors would have teleconferences in real time with patients remotely and through a secure encrypted system. In the first year, this program reached 300 HIV patients, and 2 years later, 92% of them were still engaged in care and had their virus suppressed to the extent that they were very unlikely to pass HIV on to others. Since then, this program has expanded to 3 hub sites, 11 satellite clinics, and is now providing through telemedicine social work services, behavioral health, pharmacological consultations, PrEP, and hepatitis C services. Through this setup, providers like Dr. Prasanth Bhatt, who's seen on the left smaller screen there, were able to treat patients in rural parts of Alabama through telemedicine technology while she was based in Montgomery. Here, a volunteer is posing with a nurse in Selma, Alabama, to show how this works. This organization looked at a hole in the map and transformed healthcare for people living with HIV in rural Alabama. And finally, on a personal level, understanding our risks helps us take actions to protect our own health. Although CDC recommends HIV testing for all Americans aged 13 to 64, more than half of Americans have never had an HIV test. Why? According to CDC, the most important reason, the main reason people haven't had an HIV test in their lives is that they feel they've been unlikely to have been exposed to HIV. And the second most common reason is that no one has suggested that they get an HIV test. We can use data from the maps and other data to reach wide public audiences with infographics that communicate these important nuggets of information and motivate people to change. At AIDSVu, we create infographics for various awareness days 12 times throughout the year, and we use our social media channels, our partners, and our other Ps, those are the planners and providers, to disseminate these infographics widely to their social media audiences. Last year, more than 500,000 people in the United States saw these infographics to provide more information about HIV. And we see how people react to these graphics. People who learned something about HIV that they didn't know before. People who decided to get an HIV test. People who paused to think about their own prevention needs. So it starts with a map, and by letting people locate themselves in the community and understanding their risks, we can empower people and organizations to make changes that promote health. So whether it's a programmatic change to offer more services, or a decision to locate new services in a smart way that's guided by data, or an individual asking for an HIV test from her doctor. We're all working to make HIV infections in the United States rare, and to make sure that everybody who's living with HIV finds that out promptly and gets high-quality medical care. Technology will help to get us there. Thank you.
Thank you, Patrick. What a great example of telemedicine at its best with that example. Thanks. Our next and last speaker, Kim.
Good morning. So they asked me to start with a quick introduction of myself. And so as somebody, I've run now for the state the largest nutrition programs, about 7 federal programs. You've probably heard of them as food stamps, but they are called SNAP nationally and CalFresh in California. But I want to start by saying, oh, I am jumping all over the place. There we go. I spent 20 years as an advocate, so I see myself as a member of the resistance, as a rebel who has grown up to be organizing people all over the galaxy, counties, social services, public health departments, food banks, to try to end poverty and hunger in California. So that's how I see myself. My staff said, no, we don't see you that way. We see you as Yoda. Because all you say is do or do not. There is no try. We have high goals at CDSS for ending hunger and nutrition, and we try to take small steps every day to meet them. So, and we have to have big goals because while SNAP is the #1 defense against hunger and poverty, it is the last of the safety net, of the universal safety net. It provides about $150 a month to low-income people on a nifty debit card that you swipe at the grocery store or farmer's market to buy the food you need. It's not time limited, it's not restricted by age. It is one of the great things about America, frankly, I think, that we make that stance against hunger and poverty. But in California, we have had a hard time connecting people with it. I am thrilled that we're no longer 50th. We are marching our way up. We are at 70% of access. People who are eligible participate in our program, but just to give you a hint, in Oregon and Washington, 100% of people who are eligible access our program. So we still have room to grow. What is the problem, California? We think that one of the main problems has been that we have been slow to catch up with where our customers are. By that I mean when you picture, I didn't say the word welfare, but it probably popped in your head, when you picture a person applying for welfare or your own experience of helping someone or your own family or your mom or your dad, you're probably picturing that lobby, okay? That's not where a lot of our business is happening anymore. Our moms are on their cell phones. Our moms are busy. And so more and more our counties have had to move to meet people where they are. This is Sacramento County. You know what? My screen is advancing and that one's not. Let me try it again. Boop. Yep, there it goes. Okay, in Sacramento County, new changes, faster services. You know what their motto is in Sacramento County? Call, click, come in. Hop on the phone and we'll answer it and help you with anything you need. Click. You can do this online. That mom can do it on her couch at 10 o'clock at night, can send us the paperwork she needs. Take a picture of her pay stub, send it to us. Come in only when necessary. We know you're busy. So slowly, each of our counties and our technology has been moving in that direction. We wanted to jumpstart it, and so we were very lucky to partner with our friends Code for America. Code for America came in and said, we can build an app, which I'll talk about in a second, called getcalfresh.org, which is a very, very, very user-friendly, I used to say within 10 minutes, but I think they've got it down to 7 now. They can do a few questions in plain English and find out if you're even eligible. It's not that people don't know about SNAP and food stamps and CalFresh, although we do have some brand confusion, but they may think it's not worth it. They may have had a bad experience. They may not have the time to get across town, to get to the office, to schedule an interview. So this is a great way to get them started. And our folks worked very hard to make sure that it looks like California, the people we serve. It's in English and in Spanish. It talks about getting help to put food on the table. Basic. We do have a 57-page application, but we do not ask you all these questions on this app. Let's get started. How many folks are in your house? How much money? And then, hey, great. It looks like you qualify, and it immediately connects to our government app and starts the application process. This has been so important for us to have a mobile-friendly, quick and easy start to our program because it has pierced so many myths about how hard it would be. And I'll tell you where we see the outcomes in a couple places. First and foremost, the most exciting chart in my life is these flat blue bars. What that means is the number of people on CalFresh is finally flattening out after dropping, okay? It should be dropping because the economy is getting better, but it's actually going up because our access is getting better. So that we have stopped the slide. Fewer people need us, but more of the people who need us can get us. So we're thrilled with the flat line. And then the other interesting thing is we're now at 1/3 of our applications are coming in online. Okay, we think that's going to be 50% as our application improves, the application online experience, but that's where our customer is. More and more, my counties tell me, person's going to apply online, probably on their phone, and then get service on the phone. That's how they want to be us, and so we have to change to meet them. But what's really exciting, as Code for America often says, is they don't want to take the market from government, they want to make the market. So 2 things I can see are happening on that. This was, in California, the counties really run the program, so we didn't say you have to do this. We said, this is a tool available to you if it works for you. Well, sure enough, about every week or 2, I get an email saying another county has joined in. They love this as another door into their program. That's the evidence I have. If my counties wouldn't say yes to this if it wasn't working for them and their workers and their clients. And then I'm very excited. The governor has taken the example of Get CalFresh and said, you know what, it's time for the official government website to get a makeover. We have a lovely 10-year-old application interface that basically is the application put online, no user experience, no nudges, no design. And so the governor has proposed this year that we do that. So hopefully that'll meet success in the legislature and we can start taking the lessons learned from the Code for America example and bringing it to the official mega site while staying nimble and agile. But I want to just say, as we're talking about removing barriers to health, we don't have any illusion that getting someone $150 a month is enough. It is obviously a foundation. It is critical. You can't do much more until your basic needs are met. And of course, $150 a month does not meet your basic needs, but it goes a long way towards food. So there's 3 other barriers we're trying to reduce. Cost, cost, cost. We are very happy that there are bonus bucks if you use your food stamps at the farmer's market. And what's exciting to me is not only do we have bonus bucks happening at farmers markets, we have small grocery stores piloting at how to get to retail. Because as you know, most people do not buy their groceries at the farmers market. We are at the grocery store, or we're going to be online soon with Amazon and other folks buying our groceries. So we have to figure out the technology to get the double up, the bonus money for buying fruits and vegetables into the retail market. That's the place we're pushing. A second barrier is this ease. We are doing maps very heavily at the planner stage. And now we got to get it from the planner stage out to the provider and then down to the person. So how do we take all that we know about where grocery stores that take EBT, farmers markets, social services office, food banks, public health, we know gardens, we know where these places are. How do we turn that into making it easy for people to make that easy choice to get healthy? And then thirdly, skills. We also don't think people need to be told that produce is better than fast food. People know. It's hard to do it and find the time to do it on a limited budget and have your kids eat it. Why are you going to spend $10 on produce and cook something that no one's going to eat? That's a bad choice for your family. So we want to have popular recipes, very quick recipes, kid-friendly recipes. Eatfresh.org is something we're trying to make as ubiquitous. When you get your EBT card, you're also plugged into eatfresh.org. And the videos and all the, maybe the gamification will be the next thing there, to try to make that help folks do the easy thing. So those are just some of the barriers we're trying to remove. I did just want to finish, since I started with the classic cliche, there's an app for that. When I came into government 3 years ago, I was really encouraging everyone, go fast, be agile, go nimble, do more. But I want to say, as we turn to the next couple days of this conference and start thinking about technology, that I want you to think about the surfer, and not just because we're in San Diego. But if you look at surfers out and if you haven't, you should go out to the beach and look at the surfers lining up. They spend a lot of time sitting still, and what they're doing is watching the waves and waiting for the right wave. And then when the right wave comes, you start paddling like hell and you go like hell. So as all this technology floods our sector and people are like, do an app, do a map, do this, do that, I urge you to think first and watch the waves and look for the wave and then go like hell. All right, thanks.
Thank you so much. So we're going to launch into a very brief discussion based on our fantastic panel. Let me start with Rebekah. So we've heard about different ways to use technology to promote behavior change, but as we all know, we're inundated by new games, apps, programs. So are there any common threads among some of the most successful technological interventions?
One of the things that was critical was to make sure that it was linked to real world behaviours, and we involved the community with it. So people were posting their own energy tips on a website. We were responding to them with YouTube clips to answer them. So it's important to engage people when they want, where they want, and translate to the real world. Otherwise it's a bit of fun and that's about it.
And does social media help in kind of encouraging people to continue with app use or game use?
It does. In fact, for us, it was the key recruitment tool. We used community agents who were dealing with low-income earners to actually sign people up, and it went really badly, and we were really worried in the first wave. Once we had a core group that played the game, they basically tagged all their friends in the next wave, and we sold out within 24 hours. So if you do it small and get your brand advocates, and then they will recommend, but you can't expect to just do an ad or you push it out there. You actually need the community to adopt it, and then they will tell their friends, and it's their lived experience that then actually gets people to use it and adopt it and continue.
Excellent. Lori, let me turn to you. So we've addressed ways in this panel to remove barriers and promote behavior change. And I'm sure many, if not all of you in the audience have your own examples. But why aren't more of these being scaled up, especially at smaller nonprofits and smaller local health departments around the country? Why aren't they being scaled up, and what can we do to make that happen?
So first of all, I think it's important to acknowledge that a lot of these are being scaled up. And you would be surprised by the number of marketing organizations and communications firms that maybe aren't on the cutting edge. We've certainly seen lots of examples today of agencies that are just really hankering for the latest research that they can incorporate into their campaigns and their efforts. Even when somebody knows about these tricks and knows these tweaks, you can sometimes forget, and sometimes you need a refresher. The picture I showed of the conference was actually a conference that my foundation put on. We knew that you shouldn't put the healthy foods next to the unhealthy foods, but you have to continually do audits through all of your programming and all of your meetings to make sure that you're setting people up for success. So those for the simple tweaks. Some of the things are a few of the examples that I showed, in particular the Agile science. That's not as easy to understand. The tools that our grantee developed are pretty sophisticated, though they are also intended to help a wide variety of people who are trying to do public health interventions. Because it was an academic institution, a nonprofit, their scalability is very much linked with sustainability. And so we had to work, after we had given them the grant to produce this knowledge, this website, we had to give them additional consulting to help them have a business case to think about sustaining themselves. And now they provide consulting to organizations that want to implement. So I think in some cases it's technically challenging, but in many other cases it's just kind of keeping it as a priority of something to keep checking to make sure that it's having as much impact as broadly as possible.
And does some of that depend on evaluation and showing that something is successful? And I'm sure some smaller agencies and smaller departments may not have the resources to do those evaluations.
I mean, I think when it's something that's costly, or whether there's a potential downside that it requires an evaluation, but we're really encouraging people to just try stuff all the time and iterate, and not really wait for the evidence to come in some cases. Just try it.
All right, Patrick. Yeah. So your HIV tool is incredibly powerful, relying on data and mapping. How can, outside of this HIV world, how can some of our audience members take your lessons on data and from the HIV tool and apply it in their own circumstances?
Sure. So we were really lucky in developing this tool that there's such a great data system that sits behind our understanding of the HIV epidemic. But one of the gaps that we saw was that it was primarily produced in these booklets and tables of data, and the idea that people don't always drink data in that way. And so one piece of advice I would have is to look at what public investment has already been made in understanding these health conditions. It may be from state or local or federal data collection efforts. And so there may actually be great data, and there may be an important role in the translation of that. So for us, the process of developing AIDSVu was a process of talking to the stakeholders, so the health departments, colleagues at CDC, but also community-based organizations and users of data, and trying to figure out where we could help bridge the gap between what was already being collected and how people needed to use it to develop their own programs. And then from an evaluation point of view, you sort of wondered about evaluation. For us, one of the challenges is that when you put out data like this, and it's just, you can download all the data sets, you can download the maps, whatever you want, is that we don't always close the feedback loop to sort of how it's being used. So we'll see a paper come out in the scientific literature that used AIDSVu data, and then have to backtrack a little bit to try and understand how they came to use that. So I think one is trying to identify what resources that are available, trying to talk to people who we think should be using data to motivate these changes in individual and organizational behavior, and asking, what's that translational piece? For us, it's been mapping. And then the third is having a window into how it's being used so you can do quality improvement.
Great, and it seems like in this era of big data, are these opportunities everywhere? And are they being mined?
Yeah, I mean, I think one thing that I didn't show is that the HIV epidemic is actually relates in important ways to a lot of other types of big data, including census data, for example. So poverty can tell you a lot about what to expect in terms of HIV prevalence at the county level or at the zip code level. And so I think the tools to correlate, again, data sources that may be available but not digestible in the ways that you can find them on the web is an important opportunity just to look at the big data that are available and help people in point-and-click ways decide how to shuffle them together for what means most to them.
Follow up with one last thing. Are there any specific resources where people can find that data that's very readily accessible that you would recommend?
Yeah, I mean, I think that most of the big public data systems have some version of public data explorers, and these are in the process of moving from what you used to get, for example, on the census website would be a big table. And again, I sort of grew in my scientific career sitting with piles of data tables around me, so I love that. Somebody else may see that better as an interactive map, or see that better with some other kind of visualization. So I do think that there are efforts being made across all sectors to make these databases more interactive and more accessible. And then the layer on top of that is how you get the census data talking to the HIV data, talking to the STD data. And so there are all these layers of opportunity to make the data and their relationships more transparent.
I'm one of those people who sees that data and just thinks this is scary. But hopefully journalists and others can help too, translate that data into very usable information. Kim, let me turn to you. So you serve California, which, as we know, is an incredibly diverse population. Do you have advice for others who are attempting to change behavior among populations that are diverse, both linguistically and culturally, as well as geographically?
Yeah, this is something we're really turning to tackle this year in California. I would say two things. Challenge what you think you know. When we started this, people said, oh, well, all that modernization for Click and Connect, that's great, but that won't work for seniors. Seniors are definitely going to want to come in the office and spend the day with you. Yeah, you know what? Turns out plenty of seniors are happy to deal with on the phone. And again, senior is 60 and over, so plenty of seniors are digital fluent. And we always want to have the right door available for you, whether it's call, click, or come in, all are available. But let's not make assumptions based on demographics about which door is going to be for you. But I will say, as we saw that, my favorite flat blue line, we're digging below that. And what we're seeing is that participation by people who speak English is actually going up, and request materials from us. People who request their program materials be in non-English is going down. And so we have some more digging to do about what's going on. Is that about our access? Is that about the current climate? Is that about the economic recovery hitting different people differently? But we are just this year starting to really dig into language access is the best data we have to figure out what's happening there so that we can make sure, even while we're providing standard, excellent service to all, we're also appropriately segmenting where needed.
Mm-hmm. And do you think that will help California kind of rise up from that 47th over time?
Well, frankly, I think our biggest is customer service. If we have a lot of off-ramps to getting to us when you apply, and then when we have to talk to you at 6 months and 12 months. And so who we lose at 6 months is a big exit point for us, that if you're not eligible, of course, if you don't need us, and we think that perhaps if our language access isn't strong, we're going to lose you, and if our digital is happening in English but not in other languages, we have 17 required languages, and most of our digital is Spanish as well, but I can tell you it is not, all of our digital is not in Hmong. And so how do we make sure as we go digital, we also stay accessible?
Right, and I would imagine too, so people aren't intimidated by it. They have it in their own language, they know it's accessible, right?
Exactly.
Okay, let me ask a question that I'd love for each of you to jump in on. And this is that we all know, and I can't remember which one of you touched on this, but we all know that people don't always make rational choices when it comes to our health. And I think we talked about the cookie and the apple. So what is the best way or the best ways to get people to make more rational choices? We could maybe start with you, Kim, and kind of move our way down.
I can't speak to rational. I can just say make it easy. Make it easy. I mean, I just think over and over again, it's not and not framing it as knowledge. Particularly, I think it can be very insulting and patronizing when people are talking to low-income communities about if only you knew. Frankly, knowledge is not the barrier about how to feed your family. Low-income people could teach the rest of us a lot about how to feed your family, right? It's about helping make those choices easier, affordable, and when you look at the burdens, this whole rational thing also kind of drives me crazy. It's rational. When you have $10 to feed your family, ramen is the rational choice, all right? So we have to look at what is rational and make the kale salad or whatever is the good, healthy thing not only easy, but rational given the factors in that family's life.
I'll touch back on one of the things I talked about, which is that more than half of Americans have never had an HIV test in their lives. And in study after study and in risk group after risk group or population after population, the reason is that people don't see themselves as being at risk. And so one of the ways that we try and address that, and I've seen this happen in my own experience in showing these data, is that if I'm asking you to assess your own risk, we make all kinds of allowances for ourselves of adjusting what we think our level of risk is given our behaviors. This is why I think people engage in behaviors that they may be able to say are not healthy behaviors for other people, but rationalize that somehow for themselves. And so by thinking about HIV risk not just as being about what you do, but as about being something about where you live in your community, that it's an issue for your community, then it sort of destigmatizes in a way the issue of testing for HIV. It makes it more about something that we do in our communities. And so I've given talks. I gave a talk at a college that was sort of in the sort of outer part of Atlanta on World AIDS Day several years ago. And I stayed for questions afterwards. And so a fair number of young people, college students, came up with individual questions, which is, I had no idea that Atlanta was this impacted when I saw those maps. Where should I get tested for HIV? So sometimes it's not about asking people to look at and judge their own behaviors and say I should do this or do that, but to put it in a broader context of what's going on in our communities. And I think that makes it feel a little less personal and a little bit more about what's going on in our communities.
And normalizing it.
Exactly.
Lori?
Great. I just want to first say, Kim, thanks for making that point. I use the word rational because it's kind of the word that behavioral economists tend to use, but I'll change it before I give my talk again. So I shared a lot of different, I think, things that we can do to make the healthy choice the easy choice. I think the one that I'm most excited about, and I think people understand the least and maybe take advantage of the least, is what's coming out of social psychology. So that the way that you phrase, whether you're a provider talking to a patient, trying to help them understand that they actually have some control over some part of their health, the way that you talk to them about it, the words that they use can really influence their belief that they actually do have some kind of control. And even changing the language that we use when we market different healthy products. I think that there's a lot of an opportunity there to actually change people's thoughts about something and make them want something that they weren't sure that they wanted before. And I think there's a lot of more experimentation that needs to be done, but there's a lot of interesting work coming out.
Rebekah?
I'm really good with microphones. I don't actually like the term rational because it implies moral judgment, that if it's rational, it's good. If it's irrational, therefore, it's bad and stupid. I believe that all consumers make rational decisions from their own perspective. We don't wake up in the morning and say, today I'm going to make a bad decision, and I hope it's a really bad one because that's going to be so much fun. I think people make choices that make sense to them, and that we need to see the world from their perspective. So if we see that consumers are making choices that are rational to them and that offer value to them, then the only way to change the behaviour is to basically find an alternative that offers better value. So for me, it's avoiding terms like rational because it implies the opposite is irrational, and using words like, well, what's the value proposition? Because if we pigeonhole people as being irrational, then it is patronising and it's disrespectful. And I think that what it does is it actually says then maybe they're not capable, and using other language rather than rational and assuming that everyone makes choices that suit them and offer value at the time, then we can start thinking of it differently. Look for value propositions, look for alternative value rather than...
What's good for them? What is a good choice for you?
Because their perspective is the right one for them at the time.
So your comment actually leads into our last question, which I'd love for you to all very briefly address, and that is that often programs are designed without any community involvement. And are there ways that we can better get communities and individuals involved in ways that don't tell them what to do?
Well, actually, in the last session, I just presented on service design. So design thinking, where you co-create and co-design right from the start with the people that you're trying to help, rather than being expert-led, is really powerful. It's really fun, and you come up with really innovative ways of new programs. So I would strongly suggest that people think about user-centered design and start involving people right from the start. Don't develop the plan and go do focus groups and think it's design thinking. You bring people in and you actually get them to develop the plan. Right from day one, you are working with people and empowering them to actually take control over the solutions, rather than doing it from, I guess, from the science and imposing it on people.
So I found that really compelling in the last session as well, and I think our grantees have worked to involve the people that they're trying to help in their design process. I think something that we're also always challenged to do is when we have convenings, to bring people from the communities. And a tool that somebody brought to us recently was, when you're trying to think about who to invite, think about who the obvious folks are, think about who the probable folks are, and then think about theoretical. Try to really get out of your head. If you invited the postman who works and serves the Princeton area where I work, what might they bring to a conversation? And every time, causing yourself to really think outside the box, to borrow an overused term.
I would say that we try with the infographic panels that we design one to work with community groups who may be serving. For example, if an awareness day is around a specific population, we'll try and work with community partners who can speak to what issues are most relevant in that community and address those in the infographics. But the other thing is, when we give talks about AIDSVu, we say that one important step that people can take to help raise awareness is to pick one of those infographics that we send out through social media channels on awareness days. Just pick one of those panels that speaks to you and send it on to your friends to start a discussion. What is it that you find about that that's compelling or motivating or meaningful? Because we know that when it's a friend reaching out and sharing this kind of information and pointing out what's important for them, that generates a much more meaningful discussion than if it seems to be coming from even a website that we try and make really user-friendly. And so I think involving communities in the crafting of those messages, and then challenging people to pick one of those 6 panels that comes out on Women and Girls Awareness Day, and figure out what it means to you, and then share it onward. And that starts a discussion. And sometimes we see value in those through the comments of people in social media.
I'll just offer a challenge from the government side. I feel like we're getting better and better about user testing up front. So our 6-month form, where a lot of people are exiting, we're redesigning, tested it in the lobbies here in San Diego. The governor's proposal for a new online experience, I'm sure we'll have user testing. The problem is it's only happening at the front end. And then it goes through the government pipeline of review by legal, review by translation, review by the 55 stakeholders. Then the budget people look at it. And then 2 years later, that has been wrung out of it. And we don't say that's as important as compliance at the end as a metric. So if anybody has figured that part out, come see me, because I'm getting it at the front end, but it is hard to hold on to.
And I've seen it just at a very, very personal level. Just this past weekend, we have a little strip of land in our vacant lot in our neighborhood, and we've proposed developing a pocket park. And so the city came to us and said to the neighborhood, what do you want in this pocket park? From the little kids to the teenagers to the elderly folks and the parents. And it's really nice to see, even at a very small level, the community involvement in something like that. Mm-hmm. So thank you so much for these wonderful panelists.
Thank you.